Good evening, everyone. My name is Dr. Felicia Sussman, and it is my absolute pleasure to join you this evening for another session of our webinar series brought to you by Weill Cornell Medicine, which provides world-class care at New York Presbyterian Hospital. And this is a webinar series brought to you by the Digest program. This evening, we're going to speak about a condition that is very, very common, and many people are confused actually about the condition. It is related to reflux disease, but it's not exactly reflux disease, and it's called laryngopharyngeal reflux, or LPR. We have a very, very special group of physicians that are joining me this evening who are absolute experts on this condition, and I'm so excited to introduce them tonight. One is my partner in the Division of Gastroenterology, a professor of medicine, and that is Dr. Philip Katz, and he is a nationally recognized and internationally recognized esophagologist with enormous expertise in the management of patients with LPR. I also have the pleasure this evening of having Dr. Chrissy Clark, who is an assistant professor of medicine in the Division of Otolaryngology, and she treats on a daily basis patients who suffer from chronic cough as well as symptoms related to laryngopharyngeal reflux. You can see this is a big word. It's challenging to say. And so during the course of the conversation, we'll probably say LPR just to make it a little bit easier for all of us. In addition to that, we actually have another expert on our panel this evening, and that is Dr. David Weir. And he comes to us. He is an assistant professor of medicine from the Division of Pulmonary Medicine and Critical Care. And he is also an absolute expert that treats on a daily basis patients with chronic cough. So thank you so much, panel, for joining me this evening. And we will go on with just showing a disclaimer. And for this evening, our agenda goes through the following things. How common is LPR? What is LPR? How do we actually evaluate laryngopharyngeal reflux? And what are some of the treatments that we can give our patients that are suffering from laryngopharyngeal reflux? So, with that in mind, as I mentioned, LPR seems to be a very, very common disease. So, Dr. Katz, how common is this condition amongst patients?
As you can see from the slide, very common. I saw 16 patients today. Three of them actually had symptoms that would be considered under the rubric of LPR. Two of them were men. One was a woman, which is kind of right around what we often see. I don't see too many people who are children, but one of them was 80. The other was 50. And the third was in her 20s.
Wow. So, this is a real spectrum of individuals that were coming to you with these symptoms.
That is correct. Um, Nobody smoked, I must say, but it is reported, and Dr. Weir will comment after me, that tobacco, alcohol, like many parts of the reflux syndrome or the reflux milieu, a high body mass index or being overweight seems to increase the frequency of all reflux. And although symptoms pretty much are similar across all age groups, these may be more common as we age.
So, Dr. Weir, tell me, as a pulmonologist, I'm sure a lot of the patients that you have probably have smoking potentially as part of their story, maybe, or that it might have contributed to some of the conditions they have. How common for you is some of the patients that are presenting maybe with chronic cough and smoking? Is that a big sort of epidemiological risk factor for people that have symptoms like chronic cough?
Oh, it's very common. Luckily, though, more recently, fewer people are smoking. Vaping is always on our radar as well.
Hmm.
But I see a lot of patients who are coming with cough, and they think that it might be their asthma. About 10% of the population has asthma. But of the people who have asthma, more than half of them will have some degree of reflux, which can actually make their asthma worse. And so
Yeah.
it's very important that we tease out other comorbidities that patients have who also have asthma and reflux.
Yeah. And, just before we move on from this, I think what you brought up was an important thing. The concept of vaping. Could you just talk for a minute for us about this? Because I do believe that there might be some misconceptions about vaping and its safety and whatnot. Just as a pulmonologist, maybe we can just do a little public, message about vaping, and especially if there are younger people or parents of younger people that might be, or others that are indulging in this. Could you just talk for one moment about vaping?
Well, I mean, vaping is becoming more popular. There is a misconception that well, we're not exactly sure yet because the epidemiology is still very young. But the conception is that, or the perception in the public is that it's safer. There are a lot of additives in vaping, and there is a condition known as vaping-induced lung injury, where we do see very severe lung damage from vaping. But it contributes to cough, and it makes other medical problems worse and more difficult to treat and get under control.
Great. So I just think that it's important to actually say because I do believe there's some misconception, especially amongst young people, in terms of that. So it's very common, obviously, as we can see here and we mentioned. So now, when we sit and kind of what this webinar really reflects is what a multidisciplinary round would feel like for us. And we sit in multidisciplinary rounds all the time together talking about patients, coming to a conclusion of what we should do together, and dealing with a patient that has symptoms consistent with laryngopharyngeal reflux. It absolutely requires a multidisciplinary approach. This is the type of condition that multiple different disciplines must work together to actually get to the diagnosis. So let's start with the patient. So this patient that we're going to discuss this evening is one that was from our offices and is a 55-year-old man who complains of chronic throat clearing, intermittent hoarseness, and he feels like there's a lump that's stuck in his throat. He also complains of an incessant cough. This cough is really, really bothering him. And he's not sure if it's causing difficulty swallowing, really. He just feels like there's something there, like it's just sitting in that throat. He's lost about 5 pounds as well over the past 6 months, and he thinks it's without any real significant change in his diet. And he, as you sort of mentioned, Dr. Weir, he's actually not smoking, and so that probably, hopefully, is not really part of what was going on here. But David, I would love for you to share with us when we present you this type of case. And obviously, there's some things here that I put into bold, but when you hear this type of case, work through me how you approach this and what are those features of the case that make you say to yourself, these are really the important things of this case that I'm going to start to focus on to get to the cause of what's going on.
So I'll tell you, most of the patients I see who have a chronic cough who come in to my clinic, the three most common causes are going to be something having to do with the sinuses, something to do with reflux, or something to do with asthma. And it's really important to sort of tease out where the cough or the symptoms are coming from. And usually the throat clearing, the lump in the throat, when it's coming from here, it can be really difficult because I always tell my patients your sinuses, your esophagus, your windpipe, your food pipe, they all come together in that area. And then you really have to do some sleuthing to get down to the bottom of it. It can be asthma, it can be reflux, it can be the sinuses. But then, we do more testing. In my office, we do spirometry, and we also look for airways inflammation to see if asthma could be the cause of the cough. And then I trust my colleagues to help me with figuring out if it's another etiology.
Yeah, perfect. I think what really this helps us understand is your specialty is looking at this history from one sort of vantage point, from one kind of lens. And then what's interesting is I'm sure that Dr. Clark and Dr. Katz are really probably looking at the exact same history, potentially from a totally different way. And it's really kind of remarkable how that actually works, with physicians. So Philip, just for a second, when you looked at this history, and as we could see, David is sort of going down the pathway about the cough. This is a pulmonary problem. So when you looked at the same history here, what are you actually focusing on in this history?
Uh, Multiple things, Felice. The throat clearing, intermittent hoarseness are um, associated with reflux. So I'm looking for typical reflux symptoms to go with that.
Hmm.
Heartburn, regurgitation, um, maybe legitimate trouble moving food down or dysphagia. The lump, yeah, the lump globus type sensation, the lump stuck in my throat needs a lot of deciphering. A little explanation related to when it occurs. Is it there all the time? I'm very happy if David is the person who refers the cough patient to me because it means he's taking care of the lungs, or if Chrissy Clark refers the patient to me. But a brief history looking for bronchitis, asthma, postnasal drip. I'll be honest, I stay in my lane. Um, So if I really think those things are going on, I don't take care of them myself. So I'm looking for this associated GERD symptoms in all of these
Yeah.
symptoms.
Well,
Heartburn, regurgitation.
yeah, so I think that's perfect. And I think kind of what you are speaking to is the concept of we in the three different specialties that we have in this webinar right now, it's obvious all of them are important to get to it. And the reason why we're all sitting together is because we're all contributing and potentially doing different testing, and we'll tease that out as we go through, this case further today. So the patient, as when you just focused on Dr. Katz, you started to bring up the concept of maybe this is reflux disease that is part of this symptomatology. So what I'm showing here now are three images from an endoscopy. So could you explain why an endoscopy may be done early as part of the workup of this patient? And what are we seeing in these three different pictures, starting from the left, moving to the right?
So when any patient is referred to a gastroenterologist, they tend to move towards something that offers a broad range of information, gives you an opportunity to look at structure and for evidence that would be accepted as evidence of reflux, excess acid exposure in the esophagus.
Okay.
On the left is a depiction of the junction of the esophagus and the stomach. Actually, both of those left and middle are subtle different versions of the lower end of the esophagus. Looking for what we call erosions or breaks in the lining, like a cut on the skin, or other evidence that might indirectly reflect reflux, like a hiatal hernia.
Okay.
On the far right is a retroflex view. The scope is turned on itself so that you can see the backside of the stomach and the lower end of the esophagus in a different view. You see the junction of the stomach and the esophagus. The esophagus is the whitish that part that was going to look closer to the skin, and then the orange color of the stomach, and they abut against each other in a nice tight fashion. as one would see in a normal patient.
Okay.
I see a gap between the scope and the lining in the presence of a hernia.
Okay. So when you look at this, if you were to do, if let's say you did an upper endoscopy and you look at this study, and it sounds to me like you do not see any evidence of obvious reflux related damage on this upper endoscopy, right? Because it sounds to me like you were describing seeing erosions, cuts that could have happened from acid coming up and potentially a hiatal hernia, which might mean that the sphincter or the anti-reflux mechanism is a little bit weak. We don't see that. So, but on this study, we don't see anything that looks like bad reflux disease, right?
That's correct. And as you know,
Okay.
most people with reflux actually do have normal endoscopies. That's not unusual, but it is still a useful first test to move the patient and also provide reassurance.
Okay. So now, we're still trying to understand potentially what the different symptoms are. And just, to remind everyone of the symptoms, the patient has hoarseness, the patient has a lump in their throat, the patient has throat clearing and a chronic cough. They feel like something is stuck there. They didn't really describe classic reflux symptoms, which would be heartburn or regurgitation, a feeling that fluid or food is coming up on them. So now we did the upper endoscopy, as Dr. Katz mentioned, it was normal. So, Dr. Katz, a barium esophagram. Very often, this might be part of the workup of someone with reflux disease. And can you just briefly describe to us what is a barium esophagram and why, what kind of information could it provide in the workup of this type of patient?
A barium esophagram is an X-ray study done as an outpatient. You're given a liquid contrast material to drink, sometimes multiple foods or foodstuffs, and Dr. Clark Christie's going to talk about that in a little more detail. And in this case, I would venture to say that one might do this because of the lump in the throat.
Hmm.
Get an idea whether that really was difficulty in swallowing things down, getting things moving, motility, if you would, or movement. Uh, Barium shows up black on the X-ray machine. This ruler here allows the radiologist to actually measure the height of the barium should it not go down. At the bottom, you can see the junction of where the esophagus turns into the stomach, where there's a little bubble down there. And this is nice and straight, and the barium column goes down very simply and easily. There's no picture here, but this is a normal movement of barium.
Okay. Okay. So upper endoscopy looks normal. Barium esophagram, which is looking for like maybe a really big roadmap of whether or not there's anything that's maybe blocking the esophagus or the esophagus maybe is not moving normally, and that is also normal. Okay. And then lastly, Dr. Katz, many times some of these patients just might also require if there's concern about things going down, about dysphagia, about difficulty swallowing, they might also be referred for an esophageal manometry. I know that this is not often the favorite tests of patients because it's done while they're awake, and very often the upper endoscopy, like you showed, is done very often under anesthesia while they're asleep. But could you just very briefly describe an esophageal manometry and what it's actually trying to show us? Because I can see in this picture that there's a tube that's being put down the nose and down the length of the esophagus. What is this trying to talk to us about?
So this is a very sophisticated test. When this test is ordered, it is because we're looking for some very specific things about how muscles work, how things are transported, and how things may open. We don't do it a lot, but if a patient is on the patient's on the call, if we order this, it's because we're really interested in understanding as much as we can about parts of your swallowing mechanism.
Mm.
So the tube goes down, it's positioned comfortably. You're seated in almost a completely supine or lying down position. Then we elevate the bed about 30 or 40 degrees so that you're a little bit more comfortable. We give you some liquid to swallow. It's actually salty water so that we can pick up the measurement with the sophisticated catheter. And in the next slide, we'll demonstrate to you what we can actually ascertain. So at the top, the very dark band where it looks like there's occasional opening is the upper sphincter muscle. Dr. Clark's going to talk about that in a minute when she talks about a modified barium swallow. We can see it open in a normal fashion and relax. And it measures then the movement and the contractile force of the esophagus going down. The purple is called impedance. That's showing that the bolus given is cleared. And at the bottom is the opening of the lower esophageal sphincter muscle between the esophagus and the stomach. Again, normal opening on the top, normal pressure of the upper sphincter, which could be high in someone with a lump in their throat or globus, and good opening at the bottom, although if there were delayed transit, that might not be complete.
Okay, so these are, in these two tests that we just showed, the barium esophagram and then this test, we now kind of have a sense if these are both normal, that maybe there's not a real movement disorder of the esophagus that's causing the symptoms. Is that accurate?
That would be fair. That this lump in the throat is probably not related to a traditional motility disorder.
Okay, very good. Okay, excellent. So we're moving on now, thinking more deeply about this patient. And, basically, um, when we start thinking about more about a lump, we've now done an upper endoscopy, it looks normal. We've done a barium esophagram, it looks normal. We've done a high resolution manometry, it looks normal. Dr. Clark, could you break down for us, when a patient comes in with a lump in their throat, and believe me, it's like they come in like this, pointing at it. I'm sure you see this all the time in your practice. They're like literally pointing here. It's here. I feel something right here, right here. Could you break down for us how do you actually think about this? What are the different types of things that patients are talking about potentially when they come in with that symptom?
Sure, it's a great question. I mean, when we're thinking about different symptoms in the throat, I think it's really important that we distinguish what exactly it is that the patient is experiencing, and if the problem is happening only when they're swallowing, or if it's happening independent of swallowing. Is that lump there all the time, whether we're swallowing or not, or were we really only more so experiencing issues with swallowing in and of itself? So we'll try to tease that apart by really getting at when the symptoms are happening, what's making the symptoms worse, and if swallowing is really the only thing that seems to trigger the problem. And that really gets at the three terms that are listed here. So in some patients, it may be more of a dysphagia, which means they're having difficulty swallowing. So it may feel like food or liquid is getting stuck in the throat. Maybe there's coughing after drinking liquids that might suggest that perhaps the liquid isn't going where we want it to go to the esophagus, and it may be getting a little bit too close to the airway and potentially leading to aspiration. Sometimes swallowing in the throat may feel a little bit more effortful. But in general, when we use the term dysphagia, we are saying that there is no pain associated with swallowing. When pain comes into play, we tend to use the word odynophagia, which means pain with swallowing. So basically, every time you're swallowing, you feel pain, either potentially in the throat or the chest. And then globus is a different sensation altogether, and that happens when that sensation of fullness or lump in the throat is there, regardless of whether or not we are swallowing. So basically, I will see patients who will come in, it's a very common problem in my clinic, and people will come in saying that it feels like there's something literally stuck in the throat, like that perhaps there's mucus there or there's phlegm there. It tends to overall be painless. And in the vast majority of cases, there isn't actually anything physically in the throat that shouldn't be there. It's more of a sensory phenomenon where we feel like there's something there. but there isn't necessarily something physically there that's causing it.
Mhm. You know, you actually mentioned something that I think we should just actually tease out a little bit more, and that's the term aspiration. So, Dr. Weir, I'd love for you to just talk about that because when we hear about someone with a chronic cough and we hear things like aspiration, people talk about the word aspiration. So, what does that mean? What happens to someone if they're aspirating?
Well, basically, aspiration is just stuff going down the wrong pipe. So it can come from above when you're swallowing, if you're not protecting your bronchial tree, your lungs, and it can come from stuff that comes up from below with reflux, and it can come just from naturally swallowing. The fear is, from a pulmonologist perspective, is that patients who chronically aspirate, this causes chronic inflammation in the lungs. It can exacerbate other chronic lung conditions, and it also can lead to chronic scarring, fibrosis, and even respiratory failure.
Mm. So, you know, that could I mean, it's so interesting because we're talking about something like reflux disease, which many people think of as so potentially benign. I mean, we know reflux disease is associated with the development of premalignant conditions like Barrett's esophagus and maybe esophageal cancer, and we've had webinars on that. But then the concept of what you just spoke about, Dr. Weir, the concept of reflux disease and maybe aspiration leading to really serious lung disease. Wow, I mean, that is just another whole level of, you know, the importance of really identifying potentially reflux disease, certainly. And, you know, Dr. Clark, when we think about aspiration and this protecting, could you talk about like how does that happen exactly? Like, so you swallow something and then it could go, like people always, you hear people say it went down the wrong pipe,
Mhm.
right? Like, what does that mean? What does it mean? Like, why does that happen, you know, to us? What's actually happening up there?
Sure. I mean, it can be due to multiple factors. Sometimes it can be due to weakness or changes in the throat. Sometimes it can be post-treatment for things like head and neck cancer. There can be multiple different reasons why someone may develop aspiration. And basically, we have a lot of inherent protective mechanisms that help to prevent it from happening. And cough, believe it or not, is actually one of those strong protective mechanisms. But chronic cough, we tend to think of more when it's happening at times where the cough really shouldn't be happening.
Mhm.
So that's kind of the distinction there.
Understood, understood. So coughing could actually, like you said, you realize there's something there and you cough to make sure it doesn't go the wrong way. Very
Exactly.
interesting. So now we're going to move on to different diagnostic testing. And this also is another swallow that involves barium. But Dr. Clark, could you explain to us what a modified barium swallow is that's different from the, you know, barium esophagram that Dr. Katz spoke about? I'm going to actually, you know, run this little film. And if you could actually describe for us what is this about and what does this teach us?
Sure. So first, really, when we're ordering a modified barium swallow, the goal is for us to understand what is happening with the swallowing in the throat. Now, Dr. Katz had walked us through the esophagram, which is giving us a sense of how things are transiting or going through the esophagus, but this is really more so focused on the throat and the very upper part of the esophagus, the upper esophageal sphincter. So during the study, it's also an X-ray swallow study. The person undergoing the study is eating different things that have been coated with barium, sometimes thin liquids, sometimes like a pudding consistency, as well as a graham cracker consistency. And we're watching how these things are transiting through the throat. And in this image, we can see that it's basically looking at the person from the side, kind of like this.
Mhm.
And it's a little hard for me, I don't think I can point personally, but we can see basically how things are transiting through the mouth first,
Mhm.
and how things are being handled there. And then we can also check to see if things are potentially going down the wrong pipe. Are they getting a little bit too close to the windpipe? Or are they transiting as we would expect, you know, in a smooth, coordinated fashion from the throat into the esophagus?
Wow. So this is actually, first of all, it's very different than the other tests that Dr.
Yes.
Katz was talking about. And mainly it's very different because it's really actually targeted at looking at a whole other aspect of the
Mhm.
swallowing piece. So who's actually with a patient typically when they have this test?
Yeah, the test is done in radiology, and it's done with a swallowing focused speech language pathologist
Mhm.
who will basically guide whoever is undergoing the test through the test and administer the different consistencies, and will also offer counseling afterwards as to whether any specific dietary modifications need to be made based on the findings from the test.
Interesting. And so for patients that might be, it's very scary if you think you're having difficulty swallowing, right? Or coughing from it or whatnot. So they're there actually watching what's happening. So let's say like what Dr. Weir was talking about. Let's say they start aspirating. Are they able to see this is happening and say, whoa, 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 let's stop right now because we're getting to a place that's maybe not safe?
Absolutely. And they can also trial different therapeutic interventions in real time to see if certain strategies, compensatory strategies may have benefit in terms of the swallow.
What does that mean, compensatory
So
strategies?
basically, there are multiple different, strategies that can be trialed, and it really often depends on the underlying cause in terms of what is leading to the swallowing difficulties. But basically, different techniques that can be employed during the swallow,
Mm.
sometimes like tucking your chin or turning your head to the side. It's very much patient dependent, and the speech language pathologist can help to guide that and can also assess again in real time whether or not those strategies are actually making a true difference with the
Wow.
swallowing.
So they're able to watch whether or not you do certain different things when you swallow and whether or not it actually helps, with the problem.
Exactly.
Fantastic. Fantastic. Okay, so now there's another type of test that I know, Dr. Clark, that's often done, through your practice. This is called the FEAS. So this also, it looks like the middle image here is obviously giving us another image that almost looks a little bit like the endoscopy kind of image that we sort of saw, from much higher up, and there's a little scope. So could you describe what this test is about? And I'll run this image as well. We can run it again, but what is this? Why do we do this in a patient? What's happening to them?
Yeah, so in this test, instead of using x-rays, we use a tiny flexible scope that is passed through the nose, and it allows us to see and evaluate the throat and the voice box. We'll typically start with a numbing spray in the nose before the scope just to ensure that the exam is more comfortable. And even though it might sound a little bit scary, it is typically very well tolerated. Once the scope's in place for the FEAS exam, the speech language pathologist generally, and sometimes the physician, will administer or have the patient try different foods and liquids, many times coated with food dye, like we can see in the picture on the right, so that we can see them clearly during the swallow.
Mhm.
And during the swallow, we're actively watching in real time what's happening in the throat to make sure that, first of all, everything is being appropriately cleared by the throat. And we also check to make sure that we're not in is what we call aspiration.
Mhm.
It's a very safe test, very quick. And unlike the X-ray swallow study for the modified barium swallow study, it doesn't involve risk of radiation. Sometimes we will do both exams because they can provide complementary information.
Yeah. And so on this image that we're seeing right in front of us,
Hmm.
could you describe actually let me just get it a little more forward. Like maybe this image. What
Sure.
actually are we seeing here? Because like for people that are not used to looking at this, I mean, this could be Mars that we're looking at. Like what
Sure.
is actually in front of us here?
Sure. So in this image, the scope is at the very, very back of the nose, looking down into the throat. At the very bottom of the image, we are looking at the base of the tongue, which is kind of the root of the tongue, the part of the tongue that we can't see just by looking in the mouth. The furrowed structure there is the epiglottis, which is a normal cartilage. It helps to fold over our windpipe when we swallow, over our voice box. And we can see a little hint of the vocal cords there too, those little white bands.
Mhm.
And right after the vocal cords, we can actually see into the airway. So during this exam, we can see into the trachea and see if things have gone, whatever is being swallowed has inadvertently or unnecessarily gone into the trachea.
Okay, so like that little V at the backside is kind of where those
Yes.
vocal cords are. And so this is really sort of a little bit of what Dr. Weir was actually describing before. You're able to see this, whatever's happening up in the throat, what is moving, what's not moving. I mean, can you actually see, he was describing throat clearing. Some people might actually describe hoarseness of the throat. I'm assuming that those vocal cords can also, that could provide you a lot of information you're looking at, right?
Absolutely. Usually before the feast exam, we are doing kind of a structural assessment, both in the throat as well as looking at the vocal cords, especially in a patient like this where we want to make sure that the hoarseness isn't, due to a vocal cord lesion or another possible cause of hoarseness, because there can be many different causes. So that's something that we're actively checking during this exam.
Okay, wonderful. So you're able to see all the structures, the vocal cord, whether they're aspirating, how things are moving. I mean, this is really another very special exam that provides a lot of information. So, the plot sort of thickens on this patient. He tells us of all the things, that thing that really bothers him the most is the chronic cough, actually, that's going on. So when we think about chronic cough, and obviously I'm going to turn to our expert pulmonologist, Dr. Weir, when you evaluate someone with a chronic cough, what do you do to try to make the evaluation? What does the testing look like? What are the things that you're asking about? I think you touched a little bit about on that, but could you expand?
Well, I mean, we always start with a detailed history to try and find any exposures that could be contributing to the cough. Family history, social history, smoking, vaping, alcohol, dietary history. We look at coffee. Do you like spicy foods? Also, we want to know if they've ever had any prior, ear, nose, and throat evaluation, if they've ever seen a gastroenterologist. Where do they like to travel? Do they have pets? It can be quite extensive. And then based on our answers to those questions, we try and pin down what seems to be the most common or most likely culprit in their cough. And then, the testing that we go through, physical exam, we look for wheezing and examine their airways. The chest imaging, we do chest x-rays, CAT scans, that allows us to assess sort of like the structural integrity of the lung. And spirometry is a quick test that we do in the office where we just have someone blowing into a tube where we can measure for airflow obstruction, which is one of the hallmarks of asthma.
Okay. So, I mean, it sounds like you can get a lot of information from just the history and some really non-invasive testing to get a sense of what's going on from someone from chronic cough. Okay, great. So then we move on to these things. So Dr. Katz had mentioned gastroesophageal reflux disease. Obviously, today we're talking about laryngopharyngeal reflux disease, but could we just spend a little bit of time, Dr. Weir, on asthma, COPD, interstitial lung disease, especially when we hear this thing, interstitial lung disease. I know that there's more conversation about some of these things. Where do these things all lie in the spectrum? Like what is COPD in comparison to some of these other diseases? And can all these people present with chronic cough?
Yes, all of them can present with chronic cough. Asthma, typically we think of asthma as having wheezing and allergies and shortness of breath, but there are a group of patients who have asthma who cough as their only symptom, and it's cough variant asthma. And we can usually detect airways inflammation in the office, and giving them an inhaler will make that better. There's also there's an eosinophilic, non-asthmatic eosinophilic bronchitis, which is also another inflammatory airways disease that causes chronic cough. COPD is chronic obstructive pulmonary disease, which is chronic bronchitis and emphysema. Typically, we see that in patients who smoke, but up to 25% of patients who have COPD are non-smokers. Interstitial lung disease is a little less common, but up to 80% of patients who have interstitial lung disease will have some degree of a chronic cough. And they also tend to have chronic reflux.
So talk to me about that relationship between chronic reflux and interstitial lung disease, and how important is it to actually nail that diagnosis in that patient population? And if you identify reflux early, can it actually impact something like interstitial lung disease?
I think both for interstitial lung disease and asthma, identifying reflux early is very important. We do know that, the chronic aspiration of the cough and the reflux an interstitial lung disease and an asthma actually makes the disease worse. Patients who have asthma that is difficult to control, and they also have reflux. If I'm not getting that reflux under control, I'm going to be working double time to get the asthma under control. Interstitial lung disease, the biggest thing we can do is to try and stop inflammation that leads to chronic scarring, which is what the interstitial lung disease is. It's just a scar in your lung that will not get better. Your body cannot repair it, just like your skin when you get a scar and it becomes that tough piece of skin. Same thing happens to the lung tissue. And that chronic aspiration and the coughing increases that inflammation that's there, which increases the impaired repair process, which leads to scarring and more fibrosis.
Wow. So, I mean, this just highlights why our teams work together, right? Because working in silos, just thinking about someone with a cough and not working with, other healthcare professionals thinking, could GERD be actually the reason behind this? And let's make sure that we are really attacking this. It's just the only way we can do this. You have to work together in this interdisciplinary fashion, I think, to really be able to manage these things. So we're going to move on and say, what if reflux is also really part of this, right? We've done a lot of testing so far. None of it has really shown what's exactly going on here. So Philip, tell me, Dr. Katz, if we wanted to rule out reflux as part of what's happening, what are the different tests that we really need to do that could actually nail this?
So on the assumption, and we've seen a normal endoscopy, nothing on barium, there's nothing to explain any of these symptoms that we would be comfortable with, though our differential diagnosis has been well discussed. We have two options to actually objectively document that there is acid reflux that is abnormal. That is, the stomach acid comes up into the esophagus, or perhaps higher up into the esophagus, or even violates the upper sphincter into the back of the throat. That can be done with a wireless capsule. That would be a single type of monitoring for acid that could be placed at endoscopy. Or a more sophisticated, probably more diverse way to do that would be to, again, use a thin catheter about the size of a piece of spaghetti, these days closer to linguine, and that is inserted such that there is a measuring electrode, either in the stomach or in the distal esophagus, electrodes higher, and in a way to count reflux episodes. So very briefly, what you see here at the bottom is a pH tracing, 0 to 9. We're looking for pH drops below 4, which is the dark line across. And the red below that line means that there is acid encountering the electrode. One can make the assumption here that there's one electrode in the lower end of the esophagus and one electrode higher up, approximately just below the upper sphincter. And you can see a reflux episode number 1 down in the bottom that goes all the way up, where number 1 is at the top. Or you could put one of the electrodes in the stomach and see how much stomach acid is made, and the other electrode would tell us when reflux occurs.
Okay, so this test, just to break it down, because some people may have not thought about pH since like horrors of chemistry class when they were whatever. But so acidic, this wireless, catheter is down the esophagus. And if acid passes by this catheter, it's able to detect if there's this low pH there. And then it tells you if acid came up into the esophagus, right? Is that what we're talking about?
That's correct. It indicates that there is acidity. A low pH means that there is acid in the area of the electrode.
And so how does this test, so when you do this test on someone, whether or not you're putting the tube down their nose or you're placing the catheter in their esophagus, and we've had webinars other webinars, and you can go to our series that really describe pH-based catheters and Bravo testing. But when you do that, you're looking for a certain amount of episodes of reflux that then gives you the sense that this is reflux that's happening on the patient.
Yes, we're looking for increased reflux, increased acid exposure time, or an increased number of times that a reflux episode occurs.
Okay, so you did catheter-based testing and we were able to see reflux in the upper esophagus and it correlated with the coughing. So Dr. Katz, could you talk about what does that tell you that it's correlating with the coughing? What does that mean?
So there are a couple of ways to measure a relationship between reflux and a symptom, in this case, a cough. A symptom index or a calculation that actually looks at a ratio, a ratio of the number of reflux episodes that are directly noted by the patient to be associated with a cough. So they'll push a button. Before that button is pushed, there'll be a reflux episode that triggers the cough.
Mm.
That enough times, the percentage is high enough, then that will say that the reflux correlates with the cough.
Okay, so on this test,
Highly specific.
I mean, this was really helpful test because on this test, you were able to see that when he refluxed, he was actually coughing.
More likely, when he coughed, there was a reflux episode right before it that might have generated that cough.
Right, right. But there's a relationship between the two things.
Correct. Mm-hmm.
Excellent. So that's how we then came to this diagnosis of laryngopharyngeal reflux. So let's talk about that. And, Dr. Clark, what is laryngopharyngeal reflux? This thing that we've been getting to, what is happening in it? What does it mean?
Sure. So essentially, what it means is that the stomach contents, and that can include acid, enzymes, sometimes even small amounts of food, they're coming up from the stomach into the esophagus, and they're going beyond the esophagus, and they're coming up actually into the throat and the voice box. And those structures can be pretty sensitive, and the reflux definitely can be very irritative. And this can sometimes lead to symptoms like our patient had, such as chronic cough, voice changes, frequent throat clearing, excessive throat phlegm, and throat pain.
Excellent. And so it is reflux, right? It's reflux, but it's affecting, it sounds to me like what you're saying, Dr. Clark, is it's reflux from the stomach, like when we talk about gastroesophageal reflux, but it's affecting almost different organs, just different parts of the body by nature of how high up it's actually going. Excellent. So back to our patient. Because of this diagnosis of laryngopharyngeal reflux, he was started on an over-the-counter proton pump inhibitor, and that's also known as a PPI. And after 8 weeks of therapy, he notices complete resolution of these symptoms that he has really been suffering from for quite a while. So this is really somewhat of a success story in terms of getting down to what is actually going on with the patient. But one of the things that I just want us to sort of talk about for a brief moment is that not all laryngopharyngeal reflux is actually GERD, and not all GERD is laryngopharyngeal reflux. And so they clearly had a different diagnostic criteria to sort of get to this. So, Dr. Katz, could you just describe briefly, like, do all patients with laryngopharyngeal reflux, I mean, do all of them have GERD? Because it seems to me like the acid actually has to pass by the whole esophagus to sort of get there. So, like, how do people think about this? Like, there's an intersection in this like Venn diagram here, but is there a relationship between the two? Are they sort of a continuum of a disease?
It's a very difficult question, actually. And I hate to smile kind of wryly, but the way I look at it is this. Classic GERD, as most people talk about it, you have heartburn, you have regurgitation, you feel things coming up. LPR means that whatever is in play is causing a symptom in the throat. In its purest form, it starts in the stomach and it ends up in some way, shape, or form violating the upper sphincter muscle. That protection's gone. You irritate the vocal cords, you irritate the back of the throat, you aspirate into the lung, and you have all the symptoms that this patient had. Perhaps sometimes it doesn't go down. The acid that we make sits in the esophagus after a reflux episode, and then at night it sneaks on up into the larynx. And it's not a lot of reflux, so there's no damage, there's no heartburn, but it does irritate the larynx. So that overlap is a good way of putting it. How much it overlaps is difficult, and I could go on for hours, but they're different, but in many ways they're the same.
Okay, excellent. Well, so now the last part of what we're going to talk about is, I'm sure, what a lot of people really want to understand, which has to do with how do we treat this? So we've now made a relationship between reflux disease happening and symptoms that are LPR symptoms that the patient is getting. And it kind of falls into things that involve lifestyle and potentially combating the effects of acid and maybe doing something to affect the sensitivity that we were speaking about. So, and then also potentially even protecting the lungs, if it were to lead to something like that as well. So, on this slide, there's a whole bunch of different groups of medication: alginates, antacids, proton pump inhibitors, potassium acid blockers. One of the things that I want us to start with first and foremost has to do with diet and lifestyle changes. So, Dr. Clark, could you just talk to us for a moment? How do you counsel patients? I'll obviously have Dr. Katz also comment on this as well. But for you, when you have someone that you think is having symptoms from laryngopharyngeal reflux, talk to me about lifestyle changes, diet, positioning, when they eat. What do you say to these patients?
Sure. So I'll talk with them about having smaller, more frequent meals throughout the day. I'll counsel them to try to identify their specific triggers. Now, the reality is a lot of things that we all really enjoy can cause reflux. And I think, at least for me, in terms of how I counsel patients, I will tell them to try to identify what will clearly make their symptoms worse, and then to try to avoid and scale back from those specific things. I'll also tell them to avoid lying down within 2 to 3 hours of eating, and they may want to consider keeping their bed at an incline or using like a wedge pillow. I'll talk with them about maintaining a healthy weight, stopping smoking, which can also help with reflux symptoms. Those are really the big things for me.
Excellent. And so, in terms of this not eating close to bed, like, what does that have to do with the fluid or food or whatnot coming up? Like, tell me about that a little bit. And does that, because a lot of people snack at night. I mean, it is amazing what happens with patients. They might really be really tight on what they do during the day, and then nighttime comes, they come home, and there's a lot of food that happens between the time that they come home and the time they go to bed. Is that eating close to bedtime really important?
I think it is. And I do think that even if you want to have, your bigger meals at the end of the day, that can still be okay. But I think giving yourself a little bit of time between that meal or that snack and laying down is important, from the standpoint both of the volume in the stomach as well as the effects of gravity too when you're lying down. That can also lead to increased reflux.
Yeah. So, Dr. Katz, talk to me about, because there's lots of questions in the chat that have to do with diet and lifestyle. So, first, start with this, not lying down after the big meal. In your practice, which obviously has tons of patients with reflux disease, how impactful is the timing of eating, not eating close to bedtime, and the specific foods that one eats? How impactful is this in terms of laryngopharyngeal reflux?
I believe the most important in the big picture is timing of meals and what you do after you eat.
Mm-hmm.
And perhaps volume, but that's a little harder to talk about. So the normal stomach empties 90% of what we eat in 4 hours. We empty half of it, or more than half of it in 2 hours. When you're lying down and going to sleep, you lose your ability to, or you don't swallow, you lose some of your ability to clear reflux episodes, and you change the position of your lower esophageal sphincter and the angle, so that if you lie down on your left side, you're going to reflux less than if you lie down on your right side or your back. And that's all controllable. Coffee, citrus products, tomato products, all of those things are purported to make reflux, and some of them do increase acidity. But it's real hard to stop doing things that taste good, feel good, and are hard to prove actually make reflux. So honestly, I spend little time on what people eat. I tell them to eat more slowly. Uh, 5-minute eating gives you much more reflux than 30-minute eating. And I talk to them about portion size because that indirectly probably helps with how much they put in their mouth. I honestly don't worry too much about what they eat.
Now, some patients obviously do recognize that certain things do give symptoms, and I'm sure you do obviously work with nutritionists and dietitians to help counsel patients on healthy eating habits that are related to reflux as well.
Absolutely. And trigger foods are easy. If you know it makes you burn, then you don't drink it. I mean, that really should not be very complicated. I'm not trying to be uh, condescending, but that's what these agents do. They're irritants.
Yes. So now briefly, talk to me a little bit for the next last couple minutes that we have about what's on the screen here. So are all of these agents part of what you use for reflux disease?
Uh, the alginates and the antacids, I honestly use them more for traditional GERD to treat heartburn. That's episodic. Any one of them are fine. If it's an LPR type symptom and uh, the patient also has heartburn, we use them. Uh, my portion of the practice lives with proton pump inhibitors. I don't have a favorite. I use the one that's most easily covered by insurance, to be quite honest. Although there are a lot of subtleties between them, in the big picture, they have very similar results. If you talk about 10,000 patients, and there are some nuances. And then finally, potassium competitive acid blockers is a new class of drug. It's uh, very, very, very much more powerful. It's a lot more flexible in its dosing ability than proton pump inhibitors, but it remains to be studied, particularly in uh, areas that don't involve erosions and in LPR. But this is a place to go for the most severe disease at present, and has some coverage issues.
So if the newest medication that people might see on ads and whatnot, it may play a role. That remains to be seen, but it certainly has much more acid control. And then Dr. Clark, just briefly in like one last 1 minute, neuromodulators. You spoke about the sensitivity that people might have for this. Do these play a role in treatment, especially like people with chronic cough and whatnot?
Sure, they definitely can for some patients, and in select patients, I would say, when we really do feel that there is a hypersensitivity component, some type of sensory nerve dysfunction within the throat, and things are a little bit overactive, we'll sometimes consider using these medications, kind of dull that sensation a little bit.
So they might be added on when we have tried some of these other things, diet, lifestyle, acid control. We might actually get a little bit more bang of our buck by adding on some of these neuromodulators. So people might be on more than one of these types of medicines to actually be able to get them to complete satisfaction. Well, this has been fantastic. I know I learned a lot, from this in terms of how to manage these patients. I want to thank everyone on my panel who has joined me today, Dr. Weir, Dr. Clark, Dr. Katz, for sharing your expertise, showing us really how this is truly an interdisciplinary, multidisciplinary way of managing these patients. And I want to thank the audience for joining us this evening on our discussion of laryngopharyngeal reflux. This series, our webinars continue, and please join us as we move further down in motility disorders. Our next virtual webinar is going to be on the female pelvic floor, and it's going to discuss urinary and fecal incontinence. It's on October 7th from 7:30 to 8:30 p.m. And we have together another fantastic expert panel to discuss this. Thank you again, panel, for joining us today for the webinar series that's been brought to you by the Digest program, dedicated integrated gastroesophageal treatment from Weill Cornell. Have a good evening, everyone. Thank you.